Professor Ping Yang, you're from the Mayo Clinic. We're lucky to have you here in Europe at the Lugano meeting. You've been discussing here anaplastic lymphoma kinase status. Now that's a marker and it's to do with patients who are never smokers who get lung cancer. Could you explain what this is all about?
And this is a study trying to examine how frequent this particular marker are presented in a subgroup of lung cancer patients. It's been previously reported be more prevalent in never smokers and in adenocarcinoma. That's the study we try to really accurately estimate what's going on in the subgroup.
And if you're a never smoker and you get lung cancer and you have the ALK positive marker, what have you discovered that this implies?
We found that this marker representing a subgroup of tumor are more aggressive in nature. For example, higher disease stage and poor differentiation.
And how big a difference does the marker make?
This marker really showing this group of patients would have a doubled risk for having disease progression and recurrence.
So that's a very powerful indicator of the outlook for that patient. And now, interestingly, you've been looking at assessing ALK status either by immunohistochemistry or by FISH, fluorescence in situ hybridization. What are the differences between those two techniques, and what does all of this mean for the clinician?
Yeah, right now, the gold standard is by FISH, but IHC is a more accessible test for clinicians. And so the first round, we think in our study, is using IHC, and then for some ambiguous categories by IHC, that means 1 positivity and 2 positivity by scoring, should go on for FISH for confirmation.
And have you found that there is concordance between these two techniques?
Yes, we found a 100% concordance when IHC is a 3 positivity and a FISH positive, or IHC scored 0 and then FISH scored negative. Those are being in 100% concordance. That explains about 3/4 of the patients already. So only 1/4 of the patients who are in between IHC 0 and IHC 3 should go on for FISH confirmation.
So you could use the IHC initially and then go on to FISH if you need to. This gives you, if it's positive, a doubling of the risk for progression. What would that imply clinically for your patient?
Right now, we do not have a concrete answer to that yet, but we're just thinking these patients should be more aggressively treated.
And among non-smokers, that's a difficult question, but the prevalence of this ALK positivity in the population, will that indicate anything also?
Do you mean in the patient population
or
in the
patient population and in the general population?
In general population, we do not have any data on, because this is a marker for the lung tumor. So for the lung cancer patients where we can get the tumor, we know it's more prevalent in the never smoker population, and our estimates really pointing to around 10%.
Mm-hmm. So what do you think busy cancer doctors should be doing about this finding of yours about ALK positivity being a negative indicator?
I'm thinking is that if there is a targeted drug developed, this could be a candidate for a potentially effective drug towards this marker. But right now, have no treatment indication yet.
So it's a prognostic at the moment, but until an agent has been developed, a directed agent, you can't necessarily take full advantage of that.
That's right, yeah, not mature yet for any action.
So what do you think doctors should take home from your presentation here?
I think just to stay tuned to see any effective targeted drug could be on market soon.
Well, Professor Yang, thank you very much for joining us on eCancer Television.
Yes, pleasure to be here.